Hello, my name is Jason Harvey. I'm a consultant spinal surgeon. I have a specialist interest in cervical surgery, including disc replacement surgery, and also treat lots of patients with lumbar spine problems performing simple and complex procedures. My talk is really going to be about how I use injection therapy of the cervical spine to help with my clinical practice. So in thinking about the cervical spine, I think about the symptoms being neck pain, radicular symptoms, or myelopathy with cord compression. So the aim of the practice really is to try and avoid surgery. So try and do as little as possible if we can and treat patients without surgery. And likewise, when a patient has multiple level problems within the cervical spine, what we want to try and avoid is multiple level surgery, which on occasion needs to be done. If you look at what happens with disc pathology, and this is probably one of the best studies there is, looking at the natural history, they looked at 560 patients. The first thing to note is there's quite a different set of patients. So we're talking about a symptom really of cervical radiculopathy rather than a diagnosis. And we have patients with soft disc protrusions or significant spondylitic changes. And so how they respond to treatment may be quite variable. With respect to what causes that pain, well, there certainly is physical compression of the nerve. And so there's a pressure effect and there's probably some ischemic effect. But there's also some biochemical sensitizers which are released, things such as interleukin-1 or prostaglandins. And that probably goes some way to explaining why we look at scans and there may be very large discs and relatively minimal symptoms. And again, we can have quite small disc prolapses and significantly large symptoms. The diagnosis can be quite easy with radiculopathy if it follows the normal patterns with symptoms showing normal dermatomal patterns, normal myotomal patterns. But that isn't always the case. And there's an awful lot of crossover because there is a lot of connections between those various nerve roots. And so clinically it can be very difficult to decide which actually is the level which is causing the problems. Or in fact, if it is a truly radicular problem with nerve compression or whether it's a referred pain. This is a nice study that looked at symptoms around the scapular region related to radicular symptoms. So preoperatively, they mapped out the pain around the scapular region, they had a decompression for their radicular symptoms, and the symptoms went away. And you can see that there's a map relating to the different nerve roots causing that pain around the scapular region. But then you can compare it with this diagram on the left. This is facet joint pain mapped out. This is our radicular symptoms. And you can see that it can be very difficult to decide whether we're talking about radicular symptoms or whether we're talking about neck pain symptoms referred around the scapular region. And also there's an awful lot of other diagnoses: peripheral nerve dysfunction, thoracic outlet syndrome, shoulder pathology. And then even rarer but also significant diagnoses which can be difficult to decide whether that's actually the cause of the symptoms which we may think are neck pain or radicular symptoms. So if there's a C2 compression, patient may present with neck pain and pain radiating over the posterior aspects of the scalp. A radicular symptom at C3-4 with its dermatomes over the neck may present purely with just neck pain. And I've operated on these patients, decompressed the nerve roots, and their neck pain has gone afterwards because it's radicular symptoms. Likewise, pain in a C5 distribution, which will be over the deltoid region, can be very difficult to differentiate from shoulder pain, problems such as rotator cuff, impingement, or frozen shoulder. Again, C6 radicular symptoms. As we saw before, they may have this periscapular pain. They may mimic carpal tunnel compression due to the median nerve compression. and there may be the so-called double crush syndrome. So you have compression at the wrist, compression at the neck, compounding their symptoms. In the C7 nerve root, again, referred neck pain and pain very similar to a carpal tunnel compression. And with C8 going over the ulnar border, it may mimic an ulnar nerve entrapment, either at the elbow or in Guillaume's canal at the wrist. And also, what we see is potentially thoracic outlet syndrome. We see several of these a year where patients come in with radicular type symptoms, but actually what they've got is thoracic outlet syndrome. And when you ask them carefully, what they really don't like doing is lifting their hands above their head. They say there's certain things that they just can't do. I find the best test for that, this Rouge test. You put your arms up like this and do this, and they've got true thoracic outlet syndrome. Within 30 seconds, they will really want to put their arms down. It's very, very uncomfortable for them. So it can be a bit of a diagnostic dilemma here. History and examination can help us, but there's an awful lot of pitfalls. Correlating their symptoms with radiological findings, again, can be helpful, but injection therapy may be useful in helping us to try and sort out whether this is a neck problem, a cervical problem, or another sort of problem, and also if it's a neck problem, whether it's a radicular symptom or a referred pain from degenerative changes within the neck. As Kathy's already said, the evidence is very limited, but the rationale to use it is diagnostic, find out the cause of the problem, find out the level within the neck, and also as a therapeutic treatment. So the injections that I use within my practice are a selective nerve root block, injections into the facet joint for neck pain, medial branch blocks which may be therapeutic but also may lead on to the decision to perform radio frequency ablation, and more a longer term solution for neck pain. So the aim of a selective nerve root block is to firstly therapeutic, also diagnostic, and we're trying to localize one particular nerve root which we think is causing the symptoms. So we're going to aim into this neural foramen around the nerve and inject around the nerve root sheath. Now ideally I like to do this procedure under local anaesthetic because you get quite a lot of feedback from the patient. I also think it's safer. So they're in the supine position. We take an X-ray in the lateral position first of all to find the level at which we're going to inject. We then do an oblique picture, see here, so we can see the neural foramen nicely, and aim the needle to the back of the neural foramen. And the reason for that is that we're putting the needle behind the exiting nerve root and behind the vertebral artery. So that's a safer position to put the needle in. And once we're in position that we think is appropriate, inject dye which flows up around the pedicle there. And once we've ascertained that that's in the right position, the local anaesthetic and steroid can be injected. Now, what is the evidence for that? Well, as I said, it's not fantastic, but there is some evidence to support it. There's a study of 60 patients, CT-guided injections, and they found they had a significant reduction in pain following the procedure, and that those patients who had foraminal disc herniation had the better outcome. So they did actually try and differentiate between the different types of pathology, which I think is very important with this. Further study, retrospective study, really looking at whether patients had to go on to go for surgical intervention. And the majority avoided surgery, 19 patients required surgery. Failing of that, of course, is the natural history of this. The vast majority of people are going to get better anyway. So it's difficult to know whether that intervention actually made a difference as to whether they would have had surgery or not. But it's what I use in my practice for that reason, to try and avoid surgery. And again, this study looking at evaluation of levels. So to try and guide us if we do think we are, or if we end up performing surgery, which is the right level to operate, and limit the number of levels within the neck that we're going to operate on, because that is beneficial to the patient long term. So 30 patients, and they found it was useful in deciding surgical treatment levels. With respect to cervical facet joint blocks, I use these both as a diagnostic and a therapeutic decision-making process. So if I'm unsure that they've got radicular symptoms or whether it's actually referred pain for the neck, I'm trying to avoid surgery. So if I perform the facet joint injections and we get improvement, it suggests it's not a radicular symptom, and I don't operate for axial neck pain. I do operate for radicular symptoms, so again it may help me to avoid that. And the evidence here, this is a review article looking at it, and they came to the conclusion that cervical facet blocks, the evidence is fair at best. Medial branch blocks, what we're doing is aiming our treatment at this medial branch as it comes off the exiting nerve root, and this is supplying the facet joint, and this can either be an injection of local anaesthetic or local anaesthetic and steroid. And again, the evidence for this from these review articles is that it is fair from this review article. Grade 2 evidence, which is not bad really for injection therapy articles. And here, looking at comparing local anaesthetic with local anaesthetic and steroid, there was a better outcome with local anaesthetic and steroid. If we're considering a more long-term, not permanent, but more long-term relief of the neck pain, then facet joint ablation may be appropriate. And here, the needle again is placed around the medial branch here, but this is then a current is passed through here to ablate the nerve. With time, these nerves grow back, so it's not a permanent process. And again, review articles for a long-term improvement in pain, the indication is fair. With respect to complications, we can't enter into these things without considering them. These are rare, but can be serious. They're still less than in surgical intervention, but I consent my patients for a significant number of different complications. So there's a risk of infection. This is a case report on a patient who presented several days after their injection with an epidural abscess and cord compression. Likewise, hematomas. The vast majority are extradural, but this is actually an intradural hematoma where they had to open up the cord and evacuate the hematoma. And then neural damage. I don't know if this shows up that well, but this is following injection therapy, and if we look at that middle scan there is some quite significant signal change within the cord, which is probably ischemic in origin, and injections of local anaesthetic and steroid can cause cord damage and even brain infarct because they enter the intravascular supply. So if you then look at this scan, what we're seeing is the part of the procedure of a nerve root block where the dye has been injected. You see quite nicely that the dye is going into the nerve root sheath and going up exactly how we want it to. However, if you look there, those tiny little lines, that is suggesting that there is also an intravascular flow of the dye. And so we inject this local anaesthetic and steroid, it potentially is going to go intravascularly, and that can cause the problems which we have seen with the neural damage in the cord or the brainstem. With respect to the future, well, people are trying to do different things. This is a study that came out, it's a pilot study really, it came out in September, and is looking at what they termed autologous conditioned serum. So it's prepared from the patient's own serum, and what it's doing is concentrating these antagonists to the interleukin-1 receptors. So this was what I mentioned at the beginning of the talk, the inflammatory mediators, and this within our serum blocks that. So what they were trying to do was concentrate this down and then inject it instead of local anaesthetic and steroid. They did a prospective randomized trial with respect to this, looking at the neck disability index, the neck pain disability score, and a visual analog pain score. Now, for all these parameters, both in the group that had our trial, the ACS, compared with the methylprednisolone, there was a decrease in all of those parameters. That said, the methylprednisolone showed a decrease earlier on, but didn't show such a sustained decrease in those scores. So that suggests that this may have a more long-term effect compared with the steroids. And as Kathy touched upon it, probably that effect from the steroid is short-term and gives us a window of opportunity to treat patients or accelerates the natural history. This possibly will give us a more long-term solution to it. So, what do I think about injections? I think they're useful. They help us with our primary diagnosis, but we have to be aware of anatomical variations which may make our diagnosis difficult. The aim of the use of them really is to try and elicit whether there is a simple problem which is also happening or a different diagnosis which will allow us to treat the patient more simply. So if we think they've got a double crush syndrome, they need their carpal tunnel decompressed first before we start doing any injections or anything around the neck. If we think there's a shoulder problem, either as the primary cause or a secondary cause, it may be more appropriate to treat that area first of all, but our injections may help us confirm that before proceeding to any form of surgery. And I think the biggest thing for me is it either helps me avoid or limits the extent of surgery. Thank you.